Welcome to this explainer. Today, we're diving straight into one of the most profound, yet completely automatic miracles of the human body. We're talking about taking our very first breath. Now, for most of us, it's just something we literally never have to think about, right? But the actual mechanics behind that first gulp of air are incredibly complex. And honestly, getting it right is a total race against time. So, let's get into it.
But here's the big question. What happens when our first breath is the absolute hardest thing we've ever had to do? In this explainer, we're going to look at those exact moments when human lungs just aren't quite ready to work on their own. We'll explore the science of why this happens and the absolutely incredible medical interventions that step in to save the day.
Okay, so to kick things off, let's make sure we're on the same page with our definitions. The condition at the very center of this explainer is called Respiratory Distress Syndrome, or RDS for short. Put simply, it's a severe breathing disorder. But here's the interesting part. It actually claims two very different victims. We see it a lot in premature babies because their lungs are just too immature, but it can also strike adults, specifically expecting parents, due to a dangerous accumulation of fluid. We're going to break down both of these pathways today.
All right, moving to section 1, when lungs need more time.
When we're talking about fetal lung development, time is absolutely everything. To put this into perspective, if a baby is born at 24 weeks, their chance of survival sits somewhere between 5 and 40%. But if you give that fetus just another 3 or 4 weeks in utero, getting them to 28 weeks, that survival rate shoots all the way up to about 80%. No joke. Why? Because there is a massive, highly critical period of lung development right at the end of the second trimester. Those few extra weeks literally mean the difference between life and death.
So what is the secret behind that massive jump in survival? It all comes down to one biological superhero, and it's called surfactant. Basically, surfactant is a naturally secreted detergent-like substance. I want you to imagine trying to inflate a wet balloon. It's tough, right? Well, surfactant acts like a slippery coating inside your alveoli. Those are the tiny little air sacs in your lungs. It coats them so that when you exhale, the wet sides don't stick together.
And that brings us right to the core problem of infant RDS. When a baby is born way too early, say around that 24-week mark, those surfactant-secreting cells just haven't fully formed yet. So here's what happens. Step 1, the baby attempts to breathe in. Step 2, because they're missing that slippery surfactant, there's immense, overwhelming friction. And step 3, the alveoli stick together and completely collapse. Without it, every single breath takes a monumental, exhausting effort just to pry those little air sacs open again.
Let's shift gears a bit. Section 2, RDS in expecting parents.
Now, you might be wondering how this affects adults. The crucial thing to understand here is the mechanical difference between how this syndrome operates in babies versus expecting parents. Infant RDS is caused by a lack of surfactant. It's a failure to inflate. But adult RDS in a pregnant person is caused by pulmonary edema. That literally means fluid is flooding the lungs. So in this case, the lungs are fully developed, sure, but the air sacs are essentially drowning.
So how exactly does a pregnant person's lungs suddenly fill up with fluid? Well, it all connects back to a condition called severe preeclampsia, which triggers dangerously high blood pressure. Imagine that intense pressure mechanically forcing fluid right out of the blood system and straight into the surrounding tissues. When that fluid gets pushed into the lungs, you get pulmonary edema. And that directly triggers adult respiratory distress syndrome. The parent is, terrifyingly, suffocating from the inside out.
And this leads us to a pretty stark medical reality. The only way to actually be cured from preeclampsia is to give birth. If this severe, life-threatening high blood pressure and resulting RDS happens early in a pregnancy, doctors are forced into a catch-22. They have to make an incredibly urgent decision. Sometimes, delivering the baby prematurely is the absolute only medical option to save the parent's life. But as you can guess, that unfortunately drops the baby right back into the danger zone of infant RDS that we were just talking about.
All right, moving to section 3, predicting preterm birth.
Okay, so how do doctors predict and manage all this? The first step is playing detective and looking at systemic risk factors. Recent population studies have highlighted several modifiable risk factors for preterm birth. We're looking at things like advanced maternal age, physical inactivity, insufficient sleep, and even socioeconomic factors like low educational attainment. These elements overlap in really complex ways to inflate the risk of a premature delivery. But what happens when that risk turns into an immediate physical threat of labor?
That is exactly when doctors turn to some pretty amazing biomarker technology. Let me introduce you to the FFN test, or fetal fibronectin test.
This is a diagnostic tool used to predict if a high-risk mother is likely to give birth prematurely within the next 7 days. And let me tell you, that specific 7-day window, that's the golden ticket. It buys doctors the most precious resource they have: time.
Here's how that 7-day prediction actually dictates the clinical game plan. A positive FFN test signals that preterm birth is highly imminent, which triggers immediate, life-saving medical interventions. On the flip side, a negative test often means the patient's symptoms are just a false alarm. And honestly, that's just as important. It means the patient can go home, completely avoiding highly stressful, totally unnecessary hospital stays and intense treatments.
Let's look at the solutions in Section 4, Medical Interventions for RDS.
So, when preterm birth is absolutely unavoidable, whether the baby is just coming early or the mother desperately needs a cure for preeclampsia, doctors deploy what we can call the twin solutions to infant RDS. These are antenatal corticosteroids, or ACS, and direct surfactant injections. Let's see how they work together to fight this.
The very first line of defense happens while the baby is still in the uterus. If that FFN test we talked about gives doctors a few days warning, they administer antenatal corticosteroids, or ACS, directly to the expecting parent. Think of this treatment as a massive biological jumpstart. It rapidly accelerates the fetal lung development, essentially forcing the baby's body to produce as much of its own surfactant as possible before making its grand entrance into the world.
But sometimes there just isn't enough time, or the ACS alone just isn't quite enough to do the trick. That brings us to our ultimate medical safety net, direct surfactant injections. Once the baby is born, doctors step in and physically inject artificial surfactant directly into the premature baby's tiny lungs. They are quite literally providing that slippery detergent those air sacs desperately need. This finally allows the lungs to inflate so the baby can breathe on its own. It's truly incredible.
Finally, let's wrap things up in Section 5, Summary, Breathing Easier. All right, to bring it all together, here are the absolutely crucial takeaways from this explainer. First, RDS is at its core a mechanical failure. It strikes when infant lungs lack surfactant, or when an expecting parent's lungs fill with fluid due to sky-high blood pressure. Second, when it comes to fetal development, just 3 to 4 weeks makes a staggering difference in survival odds. Third, to manage that clock, modern medicine relies on predictive biomarkers like the FFN test. And finally, when time runs out, steroid treatments and direct surfactant therapy step in to save the day. Which leaves us with a pretty incredible thought to end on. Just consider the sheer resilience of the human body when you combine it with the constant triumphs of medical science. As biomarker technology becomes even more precise and our neonatal care gets even more advanced, how close are we to making the struggle for a first breath a thing of the past? It is a truly fascinating frontier. Thanks so much for joining me for this explainer, and keep learning.